from the Army Hospital, Delhi. I'm just presenting this case because uncommon presentation and usually not a very, it's an unusual presentation and unusual intervention. So 23-year-old lady, housewife, married for 3 years, has 2-year-old son. Just prior to marriage, she had a lot of headache and it could not be diagnosed clearly because she had a postural proptosis. She used to bend forward, the eyeball used to droop down. So in the last 2 years, what she felt was when she was lying down flat, there was more deep inset of the eye, and when she was erect, the eye actually looked anophthalmic. Patient went all around many places and finally came to us because we were lucky that she came to us rather than she came to us on her own. So I come to the case straightforward for constraint of time. This is how she looks. You can see that the affected eye is actually the right eye. The eyeball looks a little deep inset and it looks more anophthalmic. And this is the lateral of the right side and this is the lateral of the left side. So you can see it's slightly deep inset. Now the patient bending forward and doing Valsalva, and you can see this right eyeball has started drooping out, and this is the lateral profile again. Now patient had undergone an MRI which showed a large venous varix in the retrobulbar region, which appears hyperintense on T1 and hypointense. Of course, it's not fat saturated sequence. You can see the extraocular muscles there, and this is a large varix. The deep inset of the eye was because since there was so much of expansion space, when the patient lies down in supine position, there's a paradoxical fallback. There's more space. Now, management strategy and approach dilemma. If it is seen by ultrasound and if it's obviously seen paraorbitally, people would like to do a paraorbital injection. But we are not very sure whether we'll do a collateral damage or what is the distal extent run of this contrast or the injected sclerosant, whether it can reach up to the cavernous sinus and produce unwanted thrombus there. Orbital surgical approach is also a possibility, catheterize and glue excision, or the dilemma was basically spill into cavernous sinus due to lack of control. And surgeons have a problem because if you're lying down supine, you can't get a good control. Because most of the problem is seen. I consulted my colleagues elsewhere also. Now, we decided to go transvenous because it was a deep-seated varix, and what you see is actually a multi-purpose 5 French catheter in the internal jugular vein. Since we are used to doing inferior petrosal sinus sampling as requested by our endocrinologists, we are usually comfortable with the territory. So we could identify the inferior petrosal sinus. And what we found was through the cavernous sinus, we could retrogradely reflex the contrast into a large, bulky area behind the eyeball, which actually fits into the clinical diagnosis of a large orbital varix, MRI aided. And that is the picture. This is the abnormal area behind the eye. But remember one thing, this we have done in supine position. So we put the patient with the catheter in the common femoral vein into a long catheter strap done. We put her in semi-prone position and we did this venogram. And you can see it fills and there's a jet. And the whole varix started growing more than how it looks on supine position. This is actually in a semi-prone position. You can see the whole contrast is stagnating in the varix and there's a jet from the superior ophthalmic vein into this varix. So 9th March, having done this venogram, we went ahead and did the intervention. We placed a microcatheter through the multipurpose 5 French and we went through the inferior petrosal sinus, and you can see the wire. We could negotiate into the cavernous sinus and we had to come to the right side. So rotating the tubes or seeing in the B plane to see that you're going into the right side, not through the intercavernous communication to the left side, is very important. Having done that, we could enter into the superior ophthalmic vein entry. It is very difficult to track. We used a Prowler 14 over a 10 wire. And finally, we could reach into the varix area. This is the Prowler catheter with the 2 radiopaque marker. And we went for a coiling. We used about 6 coils, the largest of which is 7 millimeter into 21 centimeter. And the smaller was 4 millimeter into 6 centimeter. And try to block this entire varix. You can see the coiling being done. I think it's not moving. Yeah. This is the final result. You can see the entire coil mass and no forward movement of the contrast, both in AP and lateral. We cut off the varix, and there's a good intercavernous communication, and contrast is seen going to the contralateral jugular vein. This is the radiography, shows the coil mass. This is the result. This is the pre-coiling at rest. You can see the deep inset eye, and this is how the right eye looks now. I'll take only 1 minute. I think I have time.
Colonel,
yeah,
you have 30 seconds.
Yeah, this is not playing, this video. Anyhow, I'll skip if it is not playing. I hope this video plays.
Can you?
Actually,
doesn't matter. Can you give the final comment?
Yeah, okay.
Because the case is very interesting. Go on orally.
I just want to show imaging evidence. Actually, this video shows you the evidence that the entire process is gone, and when the patient forward bends, doing a Valsalva maneuver after 1 month, we call back the patient. She's got good cosmetic results. Her headache and nausea is gone. And on imaging, you can also see that a very little sac is there, which we expect that will get thrombosed ultimately.
Colonel, what is your specialty?
I'm an interventional and vascular radiologist with the armed forces.
It's why you are so good in the little venous system. It's a very difficult case that you've done. Does somebody on the panel have this experience in this cerebral or paracerebral area? Michel? Amira? So nobody. You are the only one. So congratulations. We go on working.
Thank you.